Hey, cam followers. Well, that was stressful. Sorry that we're a little bit late. There's a few tech issues on my side and on Diane's side, but we're here and that's all that matters. And we're not going to touch anything else in case we both disappear. I would love you guys to meet the awesome Diane Messum, who is here again. She's so generous with her time, coming and talking and sharing all of her knowledge for a topic that I'm really interested in, because I don't think it gets enough attention. But first of all, Diane, please tell us a little bit about yourself so everybody can have trust in everything that you say.
Gosh, thank you, Hannah, and thank you for inviting me back. I'm getting quite used to doing these chats now and I really enjoy it. So it's really nice to be back. My name's Di and I work at a specialist referral practice in Hertfordshire called Davis Veterinary Specialists. And I've been there for 11 years as a physiotherapist specialising in small animals. But before that, I trained as a human physical therapist where I worked for 12 years. And then children came along and I had to make a decision where to specialise, and my love of animals unfortunately grabbed my attention, and I've not left or any regrets since. So we work alongside a large team of orthopaedic and neurologists primarily, but we have other specialist services which we sometimes cross over into. We're fortunate enough to have a sort of a therapy centre where we have a gymnasium, hydro suite, consult rooms, and we deliver our services from there, which cover physio, hydro, splinting and orthotics, which I have a passion for, and I work alongside the anaesthetist, the anaesthesia team, to deliver the pain clinic as well. So hopefully I can bring some of my experience to you this evening and talk about problems in the foot.
Amazing. And if you ever get a chance, guys, do go. I had the pleasure of attending. It's the most beautiful setup. It's absolutely perfect in a really nice location. It's very calm. And the fact that you've got everything at your fingertips is absolutely fantastic. Mucho jealousy here, mucho. And you get to work with one of the most amazing women in the world, which is Louise Clark. So very double jealous. This topic is really fascinating because there is not much out there. If you were to pick up a textbook and look about arthritis of the toes, I'm afraid you won't find much. And Diane did a really great talk at the British Veterinary Rehab and Sports Medicine Association recently, and I just grabbed her and said, come on, let's put this out to the population who need it. So there is going to be quite a lot in here. I'm going to let Diane take it away, as she so brilliantly does. We're going to disappear. She's going to talk through her slides, and then we'll come back at the end to answer any questions. So please just sit pretty, jot down your questions. We will come back to them. So let me share the slides, make sure that works. And then I'm making Diane disappear. Poof. I'm making me disappear. Poof. And then Diane will be able to start her slides.
I do like to talk for those of you
and there's an error here. We're going to have our videos, otherwise we won't be able to hear you, I'm afraid. I've just listened. I popped you away, and all you need to do is just look at the camera and then no one will say anything. But if I make you disappear because you don't want to, I can think, oh, let me do this. I could try and hide you. No, I can't hide you. You're there. So just stare at the screen and go for it.
I apologise if I have a serious face on for the entire talk. So I was just conscious that I have a really grumpy or serious face. But anyway, without further ado, let's go on with the show, should we say. So we're going to talk about those pesky paws. And I refer to it as the pesky paws because they are troublesome. And as Hannah has just said, I don't think they are recognised enough. And a lot of the cases that I see, my findings are incidental often, and it's usually because I've been referred a case that's potentially, has had elbow dysplasia diagnosed, has had a scope, and as part of my assessment, I always do a full, complete assessment, and these incidental findings crop up, and it's really important because we need to factor these into our management plan. So we're going to go through different conditions that we find in the foot, and we're going to cover fractures, ligament sprains, tendon strains, and particularly fractures and ligament sprains, this does often lead to digital osteoarthritis. We call it secondary osteoarthritis. I guess, are there any primary causes of osteoarthritis in the foot? I don't think we truly know, but certainly they can arise from ligament sprains and fractures. And my theory is that they could also arise from tendon strains or tendinopathies also as well. There's less common case presentations as well, like tendon lacerations. So if your pet has a cut or a laceration to the back of the limb, it's gone into a ditch, it's cut itself on an open can or something like that, you know, your dog might come out of that ditch bleeding quite heavily from this cut. So you can get tendon lacerations, and we can look at the anatomy a little further in. Abductor pilosis tenosynovitis is a bit like de Quervain's disease in human medicine. So it's a tenosynovitis or inflammation and irritation within the thumb, so the sheath and the tendon that goes into the thumb, and dogs can also get it, and there's different management approaches to that, but we're not going to have time to talk about that. It's a less problematic issue that we see a lot of. And then there's digital and distal limb amputation as well, and there may be, you know, there are a lot of pets out there that have problems with corns, for example. You know, we've got our greyhounds and other, you know, those types of breeds, and they often get corns, which a lot of the management approach has involved amputation in many cases. So I've seen a few of these cases, and the knock-on effect of that is that it affects the position of the toes in the rest, you know, in the adjacent toes, and it can result in deviation or abnormal loading, which can lead to osteoarthritis as well. So there are those that we see a lot of, and there's a different approach to managing those that I often take, and my love of orthotics and splinting comes into that as well. But again, we're unlikely to be able to cover that this evening. So let's look at fractures. And when we talk about fractures, there's different locations a fracture can occur. We can have intra-articular fractures. And I think these are the fractures that are more problematic when it comes to osteoarthritis. You can see in that image on the left that the fracture goes into the joint itself. And yes, this is a human finger, but nevertheless, the fractures, you know, the types and the description are still the same in our field. So the fracture goes into the joint, and the way it repairs, it's going to lead an abnormal joint margin, which can lead to osteoarthritis. And then you can get mid-shaft fractures, probably less problematic when it comes to osteoarthritis, unless it's set or heals in an offset position, which creates abnormal loading or changes within the joint. And then we can get avulsion fractures, and they're a way of describing a piece of bone that's come off that has a tendon attached to it or a ligament attached to it as well. So that can have consequences as a result. And this is just a slide that really goes through how a fracture heals. So you have a hematoma formation, which is new vascular supply. Then the next phase is fibrocartilage callus formation, and that's the soft trabeculae that's being created, which then goes on to the third phase, which is when you get your hard bone formation, the bony callus formation. And then you get the last stage, which is your bony remodeling. And you can see that the margin of the bone is probably going to always have an abnormality to it. And I think this is what gives us problems later down the line as well, for those that certainly go into the joint. So I just thought it was nice to have a look at that slide. But what are our goals of managing the digital fractures? If we see fractures in the toes, which, you know, they are common, we do see a lot of them. So if we do get them, depending how they've been addressed by the surgeon, the vet that has seen her case, we do need to make sure that positioning or protection is available to optimize healing. There may have been dogs that have had surgery to the toes to sort of fix the fracture and make sure it heals in an adequate position. It may be treated conservatively. So we're looking at protecting that to ensure adequate healing takes place. We need to address pain, reduce swelling, restore range of motion of the joints that are adjacent to that, above and below it. We want to restore strength and proprioception, and then restore function and performance. And you'll see the familiarity come, you know, this slide crops up as well later, and you'll see how all of these things are relevant for all of the conditions in the foot. So ligament sprains then. So I think we underestimate the amount of ligament issues we can see in the foot. And this is a diagram that shows the single toe, and the ligaments are called collateral ligaments, which means that they run either side of the joint. There's a medial one, which is on the inside of the joint, and one on the outside. And you can see the toe right at the bottom now. I don't know whether you can see my pointer, but thank you, Hannah. So you've got the toenail here, you've got the collateral ligament all the way up the toe in all three of the main joints. Then we've got this elastic ligament here, extensor ligament, and these are tendons that are just cut off for the purpose of the diagram. This is a lumbrical, which also then you've got this branch that attaches to the extensor tendon here, and that's what pulls the toe up. You've got these sesamoid bones here. So you can see, those are the main ligaments, but the medial and lateral collaterals are the ones that we're mainly focused on. And again, this is a human finger. It's the only thing I can find to illustrate what happens. But obviously, if your dog sustains an injury which results in a deviation of the one bone adjacent to another, you can see in this diagram here, so B, you've got the ligament that's been compromised because it's been overstretched, and you've got different grades of sprain, which we'll touch upon. But our main aim is, oh gosh, I've lost my pointer, there he is. Our main aim is to correct that deformity and try and position it. So we're optimizing the position to allow any healing to take place. Obviously, if it's a complete avulsion or there's a complete rupture, then surgery is most likely indicated in that situation. But if it's a partial tear, then the possibility is to pursue a conservative route. And you can see in this table here, we've got our different grades of sprains. So again, they just pulled away from human medicine and what we refer to them as when we're treating our patients in human medicine. We've got our minor sprain, our grade 1s, which are minimal lameness presentations, minimal tenderness and swelling, and no significant laxity. And that's when we've got microscopic tearing of the collagen fibres. And there's no instability on stress radiographs as well, which are often performed. Then we've got grade 2 sprains, where you have a more obvious lameness. So if your dog's more obviously lame and they have a ligament sprain, then this is what you'll see. You'll get moderate tenderness and swelling, decreased range of motion, and possible instability as well. So we've got complete tears of some, but not all of the collagen fibres in the ligament. We don't often see bony lesions in these cases, and stress radiographs may demonstrate spatial derangement. I don't know whether stress radiographs are done for the toes so much, but certainly there are other joints in the body that they would do stress radiographs for, particularly the carpus. I see a lot of. Then we've got our grade 3s, which is your complete tear or rupture of a ligament. Bony lesions or avulsions that can be frequent, which if you go back to the fracture, the avulsion where it is attached, a piece of bone attached to a ligament or a tendon. And there's obvious instability as well. And these are the ones that we need to look after with a surgical approach. We don't have any images. We don't have a lot of research on the foot in dogs, unfortunately. So a lot of what I'm delivering is what we're extrapolating. And I didn't mention in the beginning in my introduction, but I specialised in hand therapy when I was in human medicine. So I worked with hands every day, which was a delight. I loved it. I think it's so intricate and it's so such a personal, important feature of our body. And it's the same for dogs as well. So we've got to have good dexterity. We use our hands and the dogs, their feet a lot, and they've got to be comfortable. What we do know in human medicine for the metacarpophalangeal joint, which is the main knuckle, and the interphalangeal joints, which are the other two joints, we've got these collateral ligaments. And we know that in extension, so when the digit is straight, the ligament is lax. But when we bend our joints, that's when the ligament is on tension. So basically, we know that in most of the joints, in the metacarpophalangeal joint, the knuckle, basically the positioning of the ligament is what we call dorsal to the axis of rotation. So if I just bring up my pointer, the axis of rotation in the joint is around here. You can see the main collateral ligament arises just above it. So when this bone comes down into this flex position, this is when we're getting stretched. Now, this is an accessory ligament. This is, I guess, not quite as important. It attaches to what's called the volar plate, which creates additional stability in the proximal interphalangeal joint of the human hand. But the collateral ligaments are what we are mainly concerned about. In the proximal interphalangeal joint, which is this joint in human medicine, they believe, or they've identified, that the origin is closer to that axis, so you don't get as much tension. It's not as worrying if we put it into flexion. But the reason I'm talking about this is that there are positions of the digit that are going to place extra stress on the ligament, so our management has got to really consider that and make sure that we don't place it in a stretched position or stressed position, which doesn't allow adequate healing at the right phase. So in the early stages, what we want to do is make sure that it's in the most shortened position to get that scar tissue laying down, and then we can start remodeling later down the line when we're trying to restore movement again. So you can see again this image on the right hand side, just another image really that just highlights that collateral ligament I was talking about and how it's on the stretched position. The accessory is in a more relaxed position there, just because of the what it originates from and inserts onto. So collateral ligaments of the foot, so you can see another image similar. We saw the single digit, but we can see there's multiple ligaments obviously in the foot because of the 4 digits primarily that we're I suppose focusing on more here. And again, the goals for management of ligament sprains are to protect, to optimize healing, to reduce pain, swelling, range of motion, restoration, restoring strength and proprioception, and then restoring function and performance. So just going back actually aside as well. So I think what we do know though in human medicine is that if we completely immobilize the grade 1 and 2 strains for the ligaments, then it can have a detrimental effect because it could prevent well, I guess you start to get adhesions, you get joint stiffness, and that can also result in muscle weakness. So they're really trying to take a more dynamic approach to managing these, which whilst we do want to correct the alignment, you can see the toe on this dog is abnormally aligned. And there's my pointer. You can see how it's abnormally aligned here. What we ideally want to do is straighten this lower or distal component, we would call it, into a straighter position, because at the moment, the ligament on this outer side of the joint is overstressed or stretched, which isn't going to allow adequate healing. So we need to try and straighten that up. But what we can allow is allow the digit to still flex and extend to a degree, because we are protecting it in the sagittal plane, we would call it. Okay.
This is a brilliant moment to just pause and just say, as a first opinion practitioner, we see this all the time. And quite often, you know, the dog's coming for a vaccine, or it's coming for a lump, or it's coming, and you kind of say to yourself, you know, should I be attending these when it could actually be a really chronic cold injury that, you know, they're very neglected is what I'm going to say. I think quite often they're not noted. I think how much lameness they actually cause at the incident that creates the sprain, for the owner to bring them in for the attention that they deserve. So quite often they don't get looked at, do they? And you'll have an older dog come in. So this is why I'm going to ask you this question, because I know there's probably people in the audience going, my dog's feeling like that. Should I have done something? And I don't want anybody to go away feeling guilty. First of all, I want people to know it's really prevalent and you're not alone with them being like this. But once they've become quite chronic, you know, is there anything you can do? You know, if the dog's toes have been facing that way for the last 4 years.
I think, sorry, Hannah.
No, go on.
I think you've got to question, is the dog lame, and is the pain arising from that digit? And if it is, I think at this stage, so far down the line, I think you're confident in saying that you're not going to gain healing of that ligament at that stage. So it's outside of my remit, but obviously there are injections, so steroid injections may be considered. There may be some external coaptation, but again, I sort of hesitate slightly because these dogs need to use their feet. You know, they need to maintain an element of dexterity as well. And yes, if there is impact forces from the ground when they're walking, causing them pain, then we may need to consider something if they're on a asphalt hard surface, for example. I try and avoid anything like that if they're on a softer grass type surface. But I think that would be my answer to that question. I think, Hannah, have you got anything to add to that, or would you approach it differently?
No, I think you've summed up what I emailed you about only just a few weeks ago, and it was a different case, but there was similarity. You know, it was a dog that had these collapsed digits for a long time, and there was pain, like compensatory changes, in my opinion, because of the change posture, the change gait. And we really did have to try and break it down together and say, you know, how painful are they for the things that we would need to do to them to try and remedy them. It was a little teacup chihuahua, wasn't it? We were like, orthotics and shoes, and what are we going to do? And actually, are they of discomfort to that dog anymore, or have they learnt to walk quite well with them? And should we put our focus elsewhere? And I think that's the direction that I'm going to be taking with that case. But the way that you just said quite succinctly, we've got to work out whether it's still a source of pain, because otherwise, as you say, you could be hunting a needle in a haystack type when actually isn't the big dog's biggest problem. Is that fair to say?
Yeah, it could be classified as a red herring, I suppose, in many ways. And I think, I guess, if it's 4 years out, as you described, the possibility is that there's osteoarthritis in that joint, and that's the primary problem. We're dealing with osteoarthritic pain, and so we'll talk about how we manage that further down. But yeah, I think it's really interesting. So I think what we're saying is, don't rush to the vets in a blind panic because you've got a dog that's got odd feet and looks similar to the image, or maybe there may be other joints or other digits are affected as well. I think it's really recognizing whether it's a source of pain. So
yeah, definitely. And I think a take home would be, if you've got a younger dog who does come back from walk or develop an abnormal orientation of a digit, brilliant. Talk to your vet.
Go straight to the vet.
It's time to talk to your vet. And there are things that can be done. It's not first opinion work, in my opinion. You will find that your vet is likely to go, should we speak to a physio about this? But it would be lovely if we could get paw health featuring a lot higher up on people's radar for clinical exams and stuff. I almost feel like I'm fighting for the digits when reading books about OA and problems, because stifle features highly, elbow is always out there, isn't it? But the poor old digits just don't get a look in, really. But most orthopedic surgeons don't feel that they cause a huge amount of discomfort, so they don't get so much attention, do they? But anyway, so sorry, continue.
No, I love this discussion. That's why I love coming on this. But this is how we're managing, or this is how these ligaments can be managed in human medicine. And we talked a little bit about immobilization versus not immobilizing the joint. And obviously, for the first two orthotics or splints that you can see in those images, they're not something we can apply to our pets. It's impossible to isolate a digit and to immobilize it. If surgery was indicated, and I don't know many orthopedic surgeons that would repair a ligament of a toe. I've never come across one yet. But basically we would want to try and immobilize it, and so it most likely would be a sort of a Robert Jones dressing or something similar. There's a dynamic one in the middle there. You can see how it allows flexion extension whilst keeping it in the sagittal plane. And this is when we're starting to look at a more dynamic approach. And then we've got buddy strapping. And as Hannah said, I spoke a couple of weeks ago at the British Veterinary Rehabilitation Sports Medicine Association meeting. And there was a brilliant speaker from America. Oh, gosh. Hannah, help me out here.
Oh, Jennifer
Brown, yes. And Jenna was doing some amazing work with buddy strapping, and I learned something completely new, which was brilliant. And because I hadn't really thought it was possible in our small animals, but buddy strapping is possible. We use an elastic type strapping or taping technique, and it's a bit of a long haul. It takes a lot of owner management, but the outcome she's getting is amazing. So it allows her to align the digit in the sagittal plane, in the straight plane of motion that we want, and attach it to the adjacent toe, which is healthy and normally aligned, hopefully. But it just allows the ligament to heal more successfully, and it still allows the dog to be able to flex and extend the toe or the digits as it carries about its normal daily activities. And the reason why we don't want to immobilize is because it can create synovial adhesions. It can cause collagen breakdown. It can cause or result in diminished collagen synthesis and create a more disorganized collagen fibril as well. So we, hopefully if we can allow a little bit of flexion, it's remodeling at the right stage, hopefully, if we're protecting it in that sagittal plane. So
I think that's a really, just a little take home as well. I've had a number of owners over the years that have gone on a little bit of a home care mission, and they've brought in their dog with homemade bandaging and splints and all manner of things, duct tape and bandaging, and I'm like, no, please don't do this. There's a real belief that if you really, lock it down firm, because everybody goes back to casting for bones and stuff, don't they? So therefore that must be how you treat everything. Oh no, we've certainly moved on from there, haven't we? So please, guys, do not think that you need to just go and make some homemade contraption and immobilize anything. Do not do it without professional advice, because we've really changed the way that we understand tissue healing.
Absolutely, do seek the advice, and yes, and if it's necessary to buddy strap, and you live a long distance away from the person that you're getting advice from, then they may teach you how to do it if it's safe to do so. But otherwise, do seek the help of a professional. So I wanted to touch upon a couple of treatment options for restoring range of motion and improving range if you start to get a good healing structure, but you can't restore range of motion as effectively as you would like. And this is something we also use for osteoarthritis as well. So if you're starting to get stiffness or you want to manage pain, this is a technique that we would use. Now,
when you just explain to them about range of motion, because there's probably a lot of therapists listening today, because you've got a big fan club, so that's awesome. But there is probably going to be a few people going, I'm actually just about keeping pace with the level here, but there's a few things that I feel I don't understand. What is range of motion and why is it important, especially for OA? Because it really filters through many other things that we do with our dogs and cats to keep their joints as healthy as possible.
Absolutely. So range of motion is the ability for a joint to go through its normal range, I suppose. So it's the ability to extend fully or fully well, this isn't straight, I appreciate, because I'm going beyond neutral extension, but it's the ability to extend fully and the ability to flex fully. And I've got a lovely video at the end how I examine the foot. So hopefully I'll be able to show you how I examine it. And you'll be able to have a little feel of your dog's toes as well, and just feeling what normal, what range of motion is like. And you can compare it against the adjacent digits as well. So it's really important to maintain range of motion for as long as is practical. The way I describe it, for example, if I've got a dog with elbow osteoarthritis and we aren't able to maintain normal range of motion, which is his ability to fully flex and to fully extend the elbow. Now, when a dog's lying in its sphinx position, I suppose is the best way of describing it, or in sternal, we otherwise refer to it as therapists, then if it's lost its flexion, those forelimbs are going to be further in front of itself. And its ability to get up from sternal into standing is going to be much harder. It's going to have to use a lot of its abdominals. It might be pulling through its triceps, its lat dorsi, which are two muscles behind the shoulder, and it's really pulling it forward. And that's when we see these trigger points that are associated with those structures as well. And teres major is another cheeky structure that can become a problem there. Whereas if we can maintain that flexion, it's got the ability to push up against the forces of gravity and work against its body to get itself up much more efficiently, rather than trying to engage other structures where we find compensatory issues. Did that explain it well enough, Hannah?
Yeah, really. And anybody that's got any kind of fitness wishes for themselves, they've tried doing a normal press up, how much harder it is if you try and do a wide base, or if you put your arms, everything changes. So subtle a little distance, so much more difficulty to do it. And also the dogs that you're talking about in front, we also see them when they abduct out, don't they? And they kind of lay out there and pulling all through the pecs, etc. So I think range of motion is so important for normal movement, but also range of motion keeps the structures within the joint healthy as well. We need them to be performing their normal range of motion to keep the joint capsule nice and flexible, to produce the joint fluid, etc. So but I never knew, as a first opinion practitioner, that you could influence that. That was mind-blowing to me. So explain to them about what a joint mobilization is.
So basically, a joint mobilization is used to restore mobility or correct osseous alignment, or it can be, and manipulation, I suppose, is what we refer to when we're trying to do that. Now, mobilization is using our knowledge of the plane of motion which a joint moves within, or also our knowledge of the shape of the joints to promote glide and slide as well within a joint. And so we can do different types of mobilizations. We can do a physiological, which is essentially taking the joint through its normal range of motion. And if we wanted to concentrate right at the end, if a dog's lacking flexion, we would oscillate at that end range to try and see if we can promote increased range. We can also do that in a sort of do a small amplitude range to address pain as well. So we're not pushing into perhaps the phase at which it's painful, which might be at the end range, which I was describing. So we can work in the first part of the range to try and minimize pain, and that's tapping into the pain gate theory, or you're getting this endorphin release. So you get this opioid system that we're tapping into. And then we've got the accessory mobs, which is our knowledge of the glide and slide within a joint. And I've got a nice slide which will just show you shortly what we can do in the finger. So
can I just add just a little bit? Sorry, because this is just so important to me. In that CAM was created to try and give people the tools to manage their dogs better. I am a complete convert. I was trained very Western based, university training. And I really was in fear of touching arthritic joints. Once they were arthritic, it was like, oh, well, they're arthritic now. Medications. I'm just going to work on pain. So when I started my learning journey, it was mind blowing for me that I could actually flex and extend and, as you say, manipulate, mobilize a joint without making the arthritis worse. I was always of the mindset, oh, we're just going to leave it alone. I don't want to stab the beast. The idea of actually taking it through a range of motion, I could make it worse, was my mindset. Well, actually, it's not like that at all. And the idea of being able to give owners, yes, pharmaceutical, yes, nutraceutical, yes, weight loss, lifestyle modification, all of these things, but also giving them the confidence that go and see a physio, and hopefully a physio is going to give you things that your dog and you can do together. That might be some massage. That might even, if you're competent and they watch your skills, it might be that they give you passive range of motion, maybe give you some grade 1 joint mobilization type work, because, that can make a really big difference. But I don't think people realize the benefits of going to see a physiotherapist. I think they think it might be a one-hit wonder and it's just going to be a little bit of fairy dust, just that's only going to last, a couple of hours. No, not true. Go to the right physio. They will give you things that you can do. And the other thing I wanted to add to that, because it comes up all the time, is loads of owners feel that their world has got smaller with their dog. They can't walk as far. They can't, go for the hike. They can't throw the ball in. No. It's so negative. But when you get taught things like this, you can start incorporating it to rebuild your bond. You spend time together, doing things together. And please, guys, have a look into these other modalities, these other methods that we can influence OA and pain. There you go. Rant over.
But no, as you said before, Hannah, it's about lubricating that joint, ensuring the right nutrition gets to all aspects of the joint and makes it or maintains how healthy it can be. So yeah, really, really important. And you don't need to worry about the next slide too much. It really is a model that was created by a chap called Bialowski. And it demonstrates that manual therapy can initiate a number of reactions, basically. So it suggests a mechanical stimulus, which is supplied by ears, initiates a number of potential neurophysiological effects, which can tap into the pain and how the pain is managed. And also, it's producing a desired clinical outcome in the treatment of musculoskeletal pain. And we know that peripheral nervous system and the central nervous system are complex, but combined, they're responsible for the pain experience. And basically, this is a really nice diagram that highlights that. So I think what the summary really is, what we do know is that manual therapy is responsible for these neurophysiological effects to help manage pain through what we call the pain gate theory, and you'll have heard me talk about that in the past. It can reduce the nerve discharge, so how quickly the nerves are firing and sending messages to the brain, and it can reduce muscle spasm and increase proprioception as well. Or increased proprioception. There's also that nutritional aspect as well. So we're looking at the synovial fluid production, increasing that, and improving nutrient exchange through, through applying those mobilizations. And then we've got the biomechanical aspect as well. And we don't have the backup of research to say, yes, we do manage to improve range of motion long term, but there are certainly some short term benefits there. And so I think that's really important to recognize. This is just a slide that really shows and demonstrates the different grades, and this technique is a tool that a lot of therapists will be familiar with, but the grade 1 and 2 are really working out of resistance, so we're just tapping into the pain mechanisms and trying to manage pain. And then grade 3 and 4 is when we're going into resistance, when we're perhaps wanting to try and restore range of motion if there's stiffness present, for example. And then the purple arrow on the far right there is the manipulation, which we never really, we would never come across really in our small animal field. For any of you that's been to a physio or chiropractor yourself, you may have had a back problem and they might have manipulated your thoracic spine. When you hear this pop or click, that's a manipulation. So it's when they're getting that end stage range that the patient's not in control of, essentially. So this is a interphalangeal joint of the digit in the hand, so human finger, and it basically shows the shape of the joint. So you've got a nice concave shape of the joint here in your convex surface, and we know that when the finger flexes, it promotes this roll around that surface, and it also promotes a slide. So if I had limited flexion, for example, so limited bend within this joint, what I would be wanting to do is apply a force in the distal component whilst fixing the proximal component, and promoting that force in that direction to hopefully improve range, as I said. And likewise, if I'm trying to improve extension, my force would be on the underside on the distal component, so the bone furthest away from the spine, I suppose, is the best way. When I talk about distal and proximal component, I'm sorry if that's not clear. But yeah, so to promote extension, we would change our force and direction of it. So quite a nice image to back that up. So let's touch about tendon sprains, tendinopathies and lacerations before we go on to osteoarthritis. And again, similar grading system to what we talked about in ligaments. We have our grades 1, grade 2 and grade 3, and this is when we have minor microscopic tear or minimal disruption of the tendon. Then we get our more obvious tear or partial tear, which becomes more painful, and then we get a more complete tear for our grade 3s as well, and that's where surgery is often recommended for those cases. Now, I just wanted to play this little video for you. So I'm just going to play a small section, just have a little look at the tendon in the hand, the human hand, and how it works and what happens when it's lacerated in this case. So I'm just going to fast forward to the right place, hopefully.
Extra tendons. Here we have a model of a tendon to show you how it works to move your fingers. The tendons that you have damaged are
not working, Hannah, sadly.
To enable
Is it not? Oh, I'm sorry, Hannah.
No, it's okay. It's just I think streaming wise, straight from the internet onto this is just not going to work, sadly. Just a shame, because we can see all the slides at the bottom, but I just don't think that the technology is just not there today.
Don't worry, that's fine. It's
each finger.
I'm going to try.
One is called your
and move on the slide. I'm just trying to work how to move on to my next slide. Bear with me, everyone. Basically, this video was designed to almost there. Bear with me. I think I've gone on too far. Oh,
sorry.
Sorry, Hannah.
That's busted today.
There we go. So yeah, so it's a video really that showed how the tendons work, and how we have two main tendons that supply the digits in the foot. We've got the superficial one, which is the one on the outer aspect of the limb, and then we've got a deeper one as well, and they're quite intricate. And here's just a series of slides that shows how intricate this foot is in dogs, and this is the forelimb. So myology is another term for the muscles and tendons of the forelimb. And you can see this is our superficial tendon belly, muscle belly, which is red. And then it really goes down into this tendon, which then diverges off to supply each of the digits. And the superficial digital flexor tendon will insert onto the second bone, so P2 as we call it in dogs, in the digit, in the toe. And then if we strip that away, you can see the deep digital flexor tendon just underneath that, and that inserts onto the last bone in the foot, called P3. And then we've got the forefoot, and actually if you look at how many little intricate muscles there are in the foot, there are so many. And as you can see, you've got the dew claw here, which again has lots of little structures. We've got these other little structures which supply the fifth digit, and there's a couple of so it's really quite complex. And if I keep stripping it back, you can see that we're now getting to the nitty gritty. So there you can see your superficial digital flexor tendon, which are these larger tendons here. We strip it back, and we've got our deep digital flexor tendon, which is coming all the way right down to the toe, so P3. And then I keep stripping. We've got these lumbricals, we've got the interosseous muscles, and so I think we really do underestimate how complex the foot is. And then the hind limb. So we've got our calf muscle here. So we call this the gastrocnemius, and then we've got our tendinosus, semimembranosus, and gracilis that also comes down into that. We've got the superficial digital flexor tendon, again, forms this calcaneal cap, then branches off and comes into each of the toes. And then again, we can keep stripping that back to see if we can find we've got the deep digital flexor tendon here, which arises onto the medial aspect and then comes down and diverges into those toes. And so I love this aspect of my work because you do see these changes in the foot, and you know, for you, the owner now, hopefully if you've got any pets at home which have got different shaped feet to the other side maybe, or they might be similar on both sides, but I'm just going to show you how you can identify which structure is affected. And this is a lovely diagram that shows the insertion of your deep digital flexor tendon, which is the pink one here. And then you've got your superficial digital flexor tendon. So you've got your P2 and your P3 here. So basically, if this is ruptured, what happens is that you haven't got the tension here. So this joint is going to become more extended or flatter. And that's when we start to see this flattened toe appearance start to arise. And then if we have a deep digital flexor tendon, which is here, and this counterbalances the extensor, I don't know whether you'll remember on the ligament image, there was this extensor ligament which arises from the P3 and inserted onto P2, and basically this tendon sort of counteracts the forces from that. And if this is failed, then you're going to have a really strong ligament that pulls that toe up, and that's when you start to get this knocked up appearance, as I would describe it. So really, you know, quite a straightforward or a fairly simple way of identifying which structure, and but unless you're familiar with it, it's not easy to know that there's an issue there. So have a look at those slides, go back to this talk at another time, and just refamiliarize yourself with it, because you know, you may be able to identify something that might need to be discussed with your vet. And this is a dog that came to me about 3 weeks ago, and it was a dog that had jumped off the bed, I think it was, or out of the car. I can't remember the exact mode of injury, but he then became non-weight bearing lame for a few days and was quite significantly lame when he did start weight bearing, and he'd overstretched the structures at the back of his carpus. So you've got this ligament which is called the plantar ligament, and then you've got the superficial digital and deep digital flexor tendons, and he's got a little bit more extension through the carpus here, so there's a bit more of an angle here compared to his other side, which is here. But if you look down here, you can see the toe. And unfortunately, when he got to me, he was about 10 weeks out, and we were querying, okay, what are we going to do? This dog was well, it was sound when I saw it, when I examined it. So he'd obviously had an acute injury, which improved. And yes, he's got this flattered digit, but at this stage I was like, well, I'm too far out now really to try and promote healing. Surgery is probably not going to be an option at this stage, unless the carpus became more of a problem, and pancarpophoresis is something we would normally do in practice if it was a very painful joint and we wanted to stabilize it. So we've talked about how we manage this case, and in the end, at the moment, the toe's not a problem. Yes, aesthetically, it's not very pleasing, to everybody. The dog doesn't mind though. He was comfortable when I examined it. But I do want to protect this carpus long term for him. So we've created a grade 2 orthoses, which is essentially a neoprene support with reinforced strapping on it to reduce the give in the neoprene. So he has that at the moment, and we're going to be monitoring this case very carefully, because I said to the owner, if there's any further deterioration of the angle of the carpus, his wrist, then we want to be creating or looking at a stronger orthotic support. So it's looking at a more rigid type support, and it may be rigid, but it might have an articulation but stop the joint from extending too much. So there's different designs, and it's a whole new world out there for what we can provide our pets with to try and prevent the onset of osteoarthritis if surgery is not a solution for your pet. So really nice case. And again, you've seen this slide before for the others. Our aims are to protect, to optimize healing. We want to reduce pain and swelling, restore range of motion, restore strength and proprioception, restore function and performance. And those are our goals. But in some cases, it may be too chronic, as we discussed in an earlier case with Hannah.
And I think that's another point to just kind of, anybody that might have just joined us and gone, oh my God, my dog's feet looks like that. My dog's carpy look like that. No one's ever said anything. And I'll be really honest, I think, every vet practice really should have a physiotherapist in, because we're becoming much, much more attuned to musculo-physical health throughout age. And many, many dogs do come in as they get older with tendinopathy related conditions, where joints that aren't looking as they did when they were younger. But I think if anybody's looking and thinking that really rings true, go back to what Diane said earlier, which is there underlying discomfort? What, is it an issue to that dog? And have a chat with your vet, and they might want to refer you to a physiotherapist for their opinion as well. But certainly don't get yourself in a panic about it, but do seek appropriate advice. Some people might say, actually, your dog's coping really, really well, and it's not a source of pain. And if you walk on an appropriate, surface, and you don't do kind of like explosive, high impact activities, the situation your dog's in is not going to be a problem within its lifetime. Is that fair to say?
Mm-hmm. And it's interesting because the same day that we both attended a few weeks ago for the meeting, there was a vet that was cutting the flexor tendons to manage corns. And I was, it's amazing how they will just cut the flexor tendon and the dog not have a problem with it, when it's relieved of its pain that's created by the corn. So it's really interesting. Actually, a lot of dogs do. They cope without it. I guess we don't really know. It's not been researched. We don't know the long-term consequence of that. Can it predispose that patient to osteoarthritis? We just don't know that information yet. But if it's right for the pet at that time, then that's a procedure that's having excellent success rates. So, yeah.
I think as I'm getting older, I'm beginning to realise more and more that making decisions is very much like a seesaw in my head. Of, what is the problem? What is the solution? What's going to be the side effects? The case that you mentioned, that greyhound had such painful corns that it could hardly walk. So actually cutting the tendons to relieve the pressure on that part of the phalanx that was pressing on the pad, dog was happy as Larry. That was the best solution ever, because the pain of that had been way worse than what was going to happen having cut that tendon. So I think the older I get, I realise everything's a bit more grey.
Absolutely. And I think it comes with clinical reasoning. You're constantly trying to rationalise the approach and work out whether it is the right approach for that case. And, at the end of the day, there's not as much research as in human medicine, and we can only extrapolate from that. And but for something like that, it's not something we do in human medicine, I suppose is what we're saying. And we can learn from each other. It might be something that we learn from in the future. But just moving on. So, if you did have a dog that had a flexor tendon laceration or a partial tear, and I saw one a long time ago, which had a partial tear to its flexor tendon, and I saw it early enough to put it into one of these orthotics. In the middle here you can see and an example of one here, and it was actually a hind leg. But basically this orthotic is designed, it's called a motion limiting orthotic, and we placed it into the orthotic for a few weeks before we then started to reduce or increase the range of motion. So this is locked at the moment. We've got two little aspects here that lock the in that case it was the tarsus and the metatarsal phalangeal joints of the hind limb, so the tarsus being the ankle, and then we gradually unlocked it so it allowed a bit more stress on the tendon at the right stage of healing, and we had the most amazing outcome. And I haven't got it in this talk today, I'm sure I've probably used it before, but the toe had a very flat foot when it first came to me. At the end, after the rehab and management using an orthotic like this, its foot was perfectly formed in the way that its other leg was. So we managed to get a really successful outcome because we managed to get those tendon ends as close together as possible to create a strong repair, and then we started to remodel it and reorganize, I suppose, the scar tissue to be able to stretch and recall again efficiently and do its dynamic activity that it.
So how long did that take, just so people have something to
That was about 12 weeks, I would say, for that case. And I think the tear was in sort of right muscular tendinous junction where you've got a little bit more blood supply. So my theory was that the healing was going to be a little bit quicker than if it was in the tendon itself. So yes, so that was, but I've had cases that have been 16, 18 weeks before they wean out.
And what kind of intervention were they? So they were wearing this orthotic on much of the time?
Yeah, so actually for both of those cases they were 23 hours a day. So they removed the orthotic for an hour just for assessing for pressure sores, you know, allow the limb to breathe, do some cleaning of the orthotic if it was required, but my instruction was that the dog wasn't allowed to wait there, and it was under strict supervision only when they did that. So yes, it was you know, both of them were excellent outcomes. The second one was actually a common calcaneal tendon tear, which had collapse of the tarsus or the ankle joint and what we call hyperflexion of the digits. So the Achilles tendon, I suppose, is the way that most people know it by, had a partial tear to it. So yeah, so there's lots of devices out there that can help us. And you can see a type of splint that I used to make in human medicine here, and this is called a flexor hood. But what it's designed to do, the flexors are on this side of the hand, and we're trying to, after the repair has taken place, surgical repair, we're trying to keep those tendons in a shortened position. But this hood was allowing us to do some active motion and passive motion, so we called it early active motion exercises to encourage tendon gliding and to reduce what we call adhesions or scar tissue sticking down, so you don't get, you know, full range of motion. So, but we're stopping the fingers from extending fully, which would place too much stress on the tendon or stretch on the tendon too early. So, you know, we're looking at aligning those devices and sort of learning on how we can position the tendons to optimize healing. So
yeah, definitely, it's really exciting. I think people underestimate how long things take. I think also the amount of commitment from the owner to do these sort of approaches, but also just give people a brief idea of how much an orthotic like that with 2 hinge points, you know, they're generally cast for the individual, aren't they?
Yes, they are. So they're cast, well, by your therapist if they're experienced. I cast honestly every day. Well, it feels like it's every day, not quite as much as that, but I feel like I'm posting so many out at the moment. It's becoming more and more popular. And so it gets sent off to either a company that I use, as a Swedish and American company that I work more closely with. Turnaround time can be anything between 2 to 4 weeks at the moment, and cost-wise, you're talking anything, depending on the design and the complexity of the design, it can range from anything between £600, £800 and £1,200. So it just depends on the company that you're working with.
And insurance companies supportive of using these orthotics?
Yes, most of my recent patients, or I can't think of any patient that have not had it funded by the insurance company. Some insurance company may ask for a pre-authorization or advise a pre-authorization is done. So that's when your therapist will they'll see the history, and then they'll put a quote forwards and say this is recommended management because this is the problem. And, you know, some cases it's instead of surgery, and when the insurance companies see the price compared to surgery, they're like, okay, we're happy to go ahead with that. So yeah, so I haven't had any issues for anybody that's considering that.
Somebody's got a relevant question to now, so I'm going to just put it up now before we move on to OA. Because that orthotic was slightly raised from the floor, did that affect gait?
So it will do originally. So the dogs, obviously, it is more upright, but as long as they've got a contact surface, and you're probably going to need to spend a bit of time on re-educating the gait and talking the owner through techniques to try and improve the gait and the weight bearing. But I suppose it's a small compromise for the long term outcome that you're looking for. You're going to get gait changes, and you're going to hear a heavy, when the owner first sees it on their pet and they've got this, different sound as the foot hits the floor. It's a bit, you can just tell through the owner's eyes, they're just like, oh, that's going to be noisy around the house. That kind of impression. But, they soon get used to it. And many of my patients, most of my patients, they acclimatise to it so quickly. They astonish me, actually. And even if they don't, while they're in surgery in the clinic with me, they'll go home and literally once or twice on when they're at home and they're walking around like they've worn it for years. It really becomes very familiar to them very quickly. It's quite funny. I'm going off tangent slightly, but I had a patient a couple of years ago, and I knew that they were relocating to an area where I live, and I've been driving home the last few sort of weeks from work, and I keep passing this dog being walked around the ring road where we live, and it's got an orthotic on. I keep thinking, I wonder who fitted that orthotic. And then the more I pass this patient on a daily basis, I go, oh my goodness, that's my patient, and I use it in my talks. They actually let me. So yeah, anyway, it's and this dog is just, it's had it for 2 or 3 years now, and it doesn't know any different. It was a very old carpal arthritis, which is a fusion of the joint, and the owners didn't want to pursue any further surgery, and this dog is doing marvelously with it. So as an alternative,
I think we will see more and more of it. I think at the moment there's still a little bit of fear and a bit of taboo, and are they turning their dog into robo dog, and the upkeep and everything. But I think they are, as you say, the quality is getting better and better, isn't it?
Yeah.
And this one's just another quick one, because it was talking about the collapsed digits. We can't actually see the image that you're saying, guys. Totofit.com. It doesn't actually give me any clue. But have you been using anything from TotoFit, which was designed toe mats? Have you got it?
Toto mats, yeah, I've got it on videos later on. So yeah,
okay, we'll come back. That's cool. And there's just this quick one about collapsed digits. Is it okay still to do underwater treadmill if you're dealing with a dog that's got superficial digital tendinopathy type thing? I should imagine this was related to.
Yeah, I mean, it depends how long it's been a problem for. But if you've got a dog that is chronic and it's not painful, you're not looking for obtaining healing, the buoyancy of the water is going to be offloading the structure anyway. If you compare it to what it's experiencing on land, the load that's going through those tendons on land is going to be much higher than it is in the water if you've got sufficient water height in there. So yes, I don't think there's any contraindication to treating cases in the water. In many cases, I get them swimming. If I want to strengthen up the tendons, the flexor tendons, I'll recommend swimming quite often. So that would be my preference.
And then this one, which from the lovely Laura, are all toes equal in dogs? Fractures, amputations, etc. better tolerated? Lead to lower risk of complications in some toes compared to others? Very relevant before the next section.
Oh, I don't know. You said that so quickly, Hannah.
Oh God, sorry. I forgot that you can't see. Are all toes equal in dogs? Are fractures, amputations, etc. better tolerated, or lead to lower risk of complications in some toes compared to others?
I got some slides which I could open up at the end of the talk, but I'm conscious that we're talking on. I kept them I've got them in this PowerPoint, but Hannah, you'll remember I presented them at the meeting, but with using orthotics, because yes, you do get deviation of the other digits and it can lead to subsequent problems. And there's a different device for those types of cases called it's a grade 4 shoe, which cuts off just below the carpus or the tarsus, which is the wrist or the hook or ankle, and it's incredibly well tolerated. It's a really neat little design, actually, and what you can do then is add some wedges if you want to improve the alignment of the digits, and definitely, I think if they're getting pain in the joints of the remaining digits, then certainly by having something under the foot to cushion the load, then we get some really good outcomes and happy dogs at the end of it. So yeah, so if we've got time, I can show you a slide to show you what I mean.
Okay. Well, you're already at an hour, so I just thought you. So let's now do OA of the toes.
Yeah, so to be honest, some of this is repeated, so I am going to fly through it, because if you go back to my talk earlier this year, I think it was around June time, you'll probably find some of this content, but I just thought it was worth revisiting, because I think when it comes to osteoarthritis, it's really important that our main goal is to minimize pain, improve function, and improve quality of life. And we're looking at strengthening the local muscles. We want to address proprioceptive deficits and also advise on home and lifestyle modifications as well for these cases. So the NICE guidelines, I constantly come back to this with my pet owners. It's something that we have found in human medicine. Basically, these are evidence-based recommendations developed by independent committees, professionals and lay people. And it allows us to understand what information our patients need to have access to, or pet owners in this case. And there's 3 core treatments that we find are beneficial for patients with osteoarthritis in people. And it's really important because we can use this knowledge to recommend these to the pet owner. And it's really important the pet owner has a really good understanding of the underlying pathophysiology of osteoarthritis. So what causes it, what can progress it, what they can do at home to manage it. Exercise management is so key, and we're going to come back to that. And then weight loss as well. And it's not only the weight that we're taking off the joints by making sure the dog is at an appropriate weight, but also we understand that the fat cells are drivers of the inflammatory processes in osteoarthritis as well. So there's evidence that's come out a few years ago to prove that as well. So
I love the fact that you use this, because when I very, very, very first started being outrageous and going into practices saying, we can do so much better, I used to refer to this as well, because there's such a belief that we need to give them supplements, we need to be doing this, that, and the other. And when you go back to the NICE guidelines, which is pinnacle work, pinnacle guidelines for human OA, so simple, simple, isn't it? So guys, that's a massive take home. Weight loss, appropriate exercise, targeted exercise, and understanding the condition and how we can best influence it. Perfect.
That's it. And there is a known phenomenon that exercise induces hypoalgesia, or pain relief. It's another word for pain relief. And basically it's beneficial for a number of musculoskeletal pain conditions. And there's lots of research that's looked at chronic neck disorders, osteoarthritis, rheumatoid arthritis, fibromyalgia, chronic low back pain. And there's 2 ways that they think it works. There's one theory that it activates the opioid system. And that's when you get beta endorphins elevated in plasma and the cerebral spinal fluid as well. And then there's also the non-opioid exercise-induced hypoalgesia, which is our knowledge of the pain gate theory, which was developed by Melzack and Wall. And basically, you're trying to override the pain that's otherwise arises from the small nerve fibers by tapping into the larger peripheral nerve fibers to block those sensations. So there's 2 theories behind that. And then I wanted to look at what we know in human medicine. I don't think it's fair to say that we can extrapolate this information from human medicine to our dogs, because our hands aren't weight bearing. But I think it's really quite interesting to look at what's out there. And so there's 4 papers here that I've highlighted. The top left looks at 5, what we call, now these are all randomized or assessment of what's called randomized controlled trials. So we call them systematic reviews, and it's a summary of all the literature on a particular topic that meets predefined eligibility criteria. So that's really important to know. So they've looked at, taken the best studies and they've met a certain criteria. And the top left, they had 5 randomized controlled trials comparing exercise versus no exercise, and they found there was low quality evidence for small to moderate beneficial effects of exercise on hand pain, function, and joint stiffness. Now, the next one down, they took 12 studies. They looked at the effects of splints for these cases. They looked at 3 that looked at exercise, and then 2 of the studies looked at the effect of splints and exercises. So splints is another term for orthoses. And They found that there's consistent evidence that splints reduces hand pain in the short and long term, but that there's limited effects for hand exercises and a combination of both, interestingly enough. So there's support to say that some splints or orthotics are useful in hands in human medicine. And then there's another study, 21 studies, there was varied support for orthotics, hand exercises, joint protection, adaptive devices, and paraffin wax. And I don't think I've known anybody to have dipped their pets or their patient's paw into paraffin wax, but I used to do it when I was practicing in human medicine. And gosh, the relief on the owners, the patient's face, they absolutely loved it. And I did it before we then did exercise therapies and functional activities, and it did make a significant difference. But as I said, it's not something we would do.
Is that just a heat thing? Is it just heat that they think it's working by?
Absolutely. That's the only thing I can think of that's working in that case.
My dad's done it, and he was just like, it's brilliant.
Yeah, I know, and it's so simple, but I don't know. I don't think it's safe for us to be considering this. But nevertheless, could we consider using our Wheatie bags and wrapping the Wheatie bags around the paws, and then doing some of the exercises which we'll touch upon at the end. Yeah. So they found that joint protection improved function and pain in these studies, and then there was minimal evidence for paraffin wax bath, but anecdotally, which means that, from experience, that I was getting some really good outcomes anyway. And
joint protection, just because it sounds very technical, actually is quite simple. It's making sure you consider what those joints are asked to do, and coming down steep steps and sliding across laminar floors and getting caught up in, horrible, nasty, complicated rugs and walking across shingle. That's joint protection. I get really kind of like, I'm talking about joint protection. And then people go, what does it mean? I'm like, common sense, actually, quite a lot of it, isn't it?
Absolutely. Yeah. So I think sometimes we just need to be reminded of it, though. But yeah, the last study looked at 10 studies, and they varied from the use of laser, splints, massage, and acupuncture. And there was a large positive effect on night hand splint on pain, function, strength, and range of motion. So I guess it's just resting the hand overnight in an optimal position. They found that exercise had no effect although it may improve hand strength, and then laser may improve range of motion. But we do need more studies ultimately. Now, there's other studies that have looked at knee osteoarthritis. As you can imagine, there's no studies that really looked at the ankle and foot in people. So that's why I was pulling some of the information from hand osteoarthritis. But again, we've got, I suppose we can consider a weight-bearing joint when we apply it to our digits, but it is a large joint that's affected. And exercise for osteoarthritis in the knee, this study here, the systematic review, basically identified that you can get moderate effects on function and pain with exercise. And you can see there's a large number of studies in this systematic review. We've got 44 studies that looked at the effect on function of exercise. We've got 44 that looked at the effect of pain, and 13 just on quality of life, of which there is only a smaller effect, but nevertheless an effect on quality of life. But then if we look at what we've got in hand osteoarthritis, you can see the numbers of the studies that are available in this Cochrane review were so small. There was 4 that looked at function, 5 of pain, and 1 quality of life. And as you can see, there was only small effects noted. So I don't know whether we can confidently extrapolate that information from human medicine to our dog's paws. I think we need to be focusing more on the weight-bearing joint, myself personally, but I'm happy to be proven wrong. But yeah, so there's other physical therapies, and I'm not going to be going into all of them today. We've got our electrotherapies, our laser, pulse magnetic field therapy, shockwave in some cases. There's radio frequency therapy as well. Indiba is becoming very popular. There's different manual therapies like massage and stretching if it's appropriate, and then there's targeted exercises as well. I'm going to come to exercises shortly for the foot. But laser, I just thought I'd pop these in because I think it's always a question that people are asking about laser and what it does and is it effective. It's an application of specific wavelengths of light for a therapeutic effect, interacts in the tissues and improves the transport of nutrients across cell membranes, and improves, it results in a cascade of effects improving cell function essentially. So really some nice results with laser. I don't use it as a standalone. I usually use it as an adjunct, so in additional to something else is my approach to that. Then if we look at the studies, This study shows that it reduces pain and disability in knee osteoarthritis. It also shows that low level and high intensity are beneficial as adjuncts to rehab exercise and reducing knee pain and stiffness and improving function. But if we look at our animal models, yes, there's still some positive results there. There's a model here that looked at knee osteoarthritis in animal models, and there's a positive effect if you've got the proper irradiation and adequate time that is delivered for. And then also elbow osteoarthritis as well. There was a greater reduction in pain at those recommended settings as well. So there are some papers coming out. Now,
I think a perfect chance to pause and be everybody's lovely hand-holding OA mother. We get asked a lot about laser. We get asked a huge amount. And I feel such a party pooper when I say, well, you do need to kind of like commit to a course, and you need to be making sure that you use it in the appropriate location. And I think there is a lot of people out there that believe you can kind of go and have one kind of episode and that's it. It doesn't really work like that, to give it its fair dues. What kind of courses do you do? Do you do like twice a week for 3 weeks and then look back and go, come on guys, right, are we getting what we need out of this? What's your protocol?
It depends what I'm seeing. I will see acute cases twice a week, but most cases are coming back to us once a week. So I usually will apply it before they have hydrotherapy, for example, to optimize or minimize pain relief while they're performing exercise, because if you can minimize pain relief, and again, the same applies for adequate medication as well, and pain relief through that form, is that you can minimize pain, they're going to perform more effectively in the water, you get a better return on your investment in rehab if you're minimizing pain. So that's where I use it, or I might use it after the session if I want to make sure that they're not getting any post-exercise soreness as well. So it does vary, but generally it'll be once a week for those that are undergoing it, twice a week if I'm seeing something more acute, and I feel it's going to benefit the healing and the speed and quality of healing, certainly.
And do you kind of go, right, let's be really objective before I use it, and then we're going to have a set number of applications, we're going to be really honest, are we seeing the benefits that we need? How do you use it?
I don't, Hannah, it's because I don't use it as a standalone, and I don't think I can measure it in that way because I'm doing lots of other things at the same time. So I find it difficult to measure the outcome. So rightly or wrongly, I think, yes, we do need more research out there, and a lot of the research is funded by laser companies. but yeah, I think, I don't know. How do you, what's your thoughts?
I think it is difficult because the cases that we see in first opinion practice often are multi-morbidity. So it isn't going to be a case of just the stifle on one side. It's going to be a number of things that have built up over years. Many of my clients aren't insured. So I tend to have a real policy of, we will approach everything in a multimodal manner. So I wouldn't use laser on its own and think it's going to cure the world. It just won't. And I talk about our objective monitoring before. Where are we? And then I suggest that we do at least 1 to 2 for a 3-week period. So that would be about 6 in total. And then I say that's a point where we can really make a judgment call together. Have we got improved pain, improved quality of life, improved mobility? What were your markers? Have they changed? Mood, behavior? What about how does the joint feel? Have we got a greater range of motion? And I think for me at the moment, I have a really honest conversation with the owner, because if they don't feel it's offering benefit, I want them to invest what they've got in something else that might offer more benefit. And I don't want them to lose faith in me. I wouldn't want them to keep coming back on a weekly, bi-weekly, monthly basis going, I don't really know what she's up to, but, I'll keep getting told to come back. I want them to be part of the decision, So rightly or wrongly, that's kind of how I'm approaching it.
I 100% agree. And I think it all boils down to the initial assessment. You're looking at what their goals are, for their pet, them and their pet, and managing their expectations as well, really importantly. And if you're suggesting something, yes, you need to reevaluate the effect of it, and not just doing the 10 sessions because they paid for 10 sessions. And that's what you've got to do. If it's not having an effect by session 4 or 6, then you need to change your approach. So that's why I'm not such a big fan of selling huge packages. So we don't do that at Davies. We don't take that approach. But it's I think what you're suggesting, 6 is a perfect number to reevaluate. I just start concluding really. Physio assessment of the distal limb. So when I've got a patient that comes in that's got suspected foot pain, then I'm looking at them when they come in the door. I'm looking at their posture and their conformation and stance, and I'm looking at abnormalities. Can I see any obvious abnormalities, joint enlargements or wound presence? You know, is there dressing in place, or is there, you know, is there any old wound that you can identify? And this is before I've really put my hands on them, really. Is there anything obvious? Then I'll look at the gait analysis, so I'll see whether there's a lameness present. I haven't got it in this slide, but I'll also be looking at how they're moving between transfers as well, and that's their ability to get up and down off the floor, you know, from sitting to standing, standing to sitting, looking at their control. And then I start to look at palpating. So this is when I do more superficial palpation to start off with. And I'll have looked at the rest of the body, but when it comes down to the foot, I'll be feeling in the antiphalangeal joints, the metacarpal phalangeal joint, and the metatarsal phalangeal joints, looking for joint thickening and comparing it with adjacent digits and the opposite limb as well. So I'm looking for joint remodeling of other joints in the limb as well. Like I said before, I have dogs that refer to me with elbow dysplasia that I find incidental digital OA, and I say to you, no, listen, there's clinical signs that there's possible osteoarthritis in the digits. We don't know for certain, there's been no x-rays, but there are signs that suggest there's loss of range caused by something. And in my opinion, I've got enough experience to sort of, you know, you feel and you've either felt joint thickening or you've felt a hard end feel when you're assessing range of motion, which we'll come on to. So I'm looking for soft tissue changes, tendon thickening, or whether there's perhaps a mass present, looking for muscle asymmetry, so more obvious at the top of the limb, you know, is it affecting the way that they're loading the limb? I assess joint range. As human physios, we will always talk to clear the cervical and lumbar spine, and really that's to make sure there's no peripheral nerve involvement that's causing a lameness in that limb as well. And I think, you know, we should be factoring that into these cases as well. And then testing collateral ligament integrity and doing joint stress tests if it's appropriate in the conscious patient.
I'm doing a lot.
I'll just go back before I start that because I'm going to let that run. But did you want to say anything before I move on?
No. I just think I really want people to be appreciative of how much cognitive processing is going on when you're just thinking out their dog. I think people really don't realise how magic the hands and eyes of a physio are. You know, you're taking in so much information, aren't you?
Absolutely. And I suppose that the years you've been in the industry, it becomes automatic, and you know, but I'm going to show you the next video, and I'm going to let you listen to me talking on the video because it just is a quick idea of how I approach assessment of the limb, and actually the way I've done it, hopefully it might allow you to then maybe have a little look and a feel of your own pets in the way that I do in this video. So have a little watch and listen. Okay, so this is just a brief examination of the foot. By this point, I've already examined for muscle asymmetry in the quads, the hamstrings, felt for any joint thickening, the stifle, ruled out anything going on there. Feel for the tarsus, feel for any thickening in the Achilles tendon. And then we're coming down to the toe, okay? And if I just place one foot slightly in front of the other, you'll be able to see what I'm doing with both hands. So I always have my hands on both hind limbs to compare. What I'm doing here now is just feeling over the tops of the toes, running my thumb over the tops of the toes, one at a time. So I'm coming to the second from the inside digit or toe, the third from the inside digit, and then the outside. And what I'm feeling here in Pebble's case is a thickening or an enlarged joint. And by comparing it one side to another, I can feel there's an obvious difference there. Okay, so this is just a brief examination of the foot. I'm going to fast forward. I just pressed something by accident. I just asked Pebbles. Sorry, Hannah. That was me.
No, it's hilarious today.
Hold on, I don't know where I've got to. Let me see. And by comparing it one side, there's an obvious difference.
Perfect.
Also assessing range of motion. And then just ask Pebbles to flex up. Sweetheart. And what I'm going to do is block above the joints, the metatarsal phalangeal joints, we call these joints here, so the knuckles, okay? And what I'm going to do is gently flex. Now, in Pebble's case, I can't flex further than what you can see there. But if I compare that to the toes of the adjacent, you can see how much I can flex the toe. In that joint, you can see how much further it's going. That's the second from the inside toe, called the outside toe. And then this is the first, the one on the
twist inside. So just coming back to this outside one, you can see how little range there is there. And that's one way that you can identify whether your pet has osteoarthritis. Okay.
Okay, so yes, so that was, let me just pause this a second. That's one way of identifying whether your pet's got loss of range of motion. You can't identify whether it's osteoarthritis. That was incorrect for me to say that. But certainly, you know, if there's clinical signs that there's loss of range there, then and there's pain associated with that range of motion examination, then it may be worth discussing with your vet whether it needs to be managed in any way, particularly if your pet is lame.
So let's just pause here and just give people a little bit of kind of happiness. So I would imagine that many people watching this are going to go and look at the dog's feet and go, I see loads of them. I see all the cauliflower knuckles. And, you know, a lot of dogs will have thickened, restricted joints, interphalangeal joints, as you say, metacarpophalangeal joints. I think first thing is that I do meet ones that are restricted and thickened, but I can't elicit pain. Do you have that as well?
Yes, and that Pebble was exactly like that, actually. She came to me with a really low-grade lameness, but nothing could be identified anywhere else in the body. And that was the only thing I could find in the leg that she was lame on. And she was painful on examination of it. And she was just going through a small acute period, but she has been pain-free for months. And she comes back every now and then for a checkup. And she's doing brilliantly. So, you know, it's not, I don't mean to be doom and gloom and you know, like Hannah said.
No.
Yeah,
absolutely. Because there was a new piece of work that came out, well, it's been around for a bit, Duncan Lascelles' work, about how they did a study in dogs and 40% of dogs of all ages had radiographic changes of OA in at least one joint. So 40% of all dogs. But only 57% of them were actually clinical. So there was radiographic evidence of joints affected, but when the stress tests were placed upon them and clinically examined, no pain response, no behavioural response was elicited. So just to make some people feel a little bit happier, you might have thickened knuckles, but they might not be clinical. But what did you do with that? Because I'm beginning to play with my hands already. I can't help it. I'm doing some tractions and I'm doing some, oh my god, just get my hands in there. So what kind of things would you do? Because people will be like, well, great, now you've made me miserable, what am I going to do about it? What sorts of things?
So mostly this dog was doing agility, but mainly it was lifestyle changes at home. I made some changes to what exercise the dog was doing and how often and the length of time each exercise session was. And we talked about what it was doing at home, you know, on and off the sofa, you know, jumping off the bed, things like that. And that was the mainstay of it to start off with, to be fair. And the owner came back and she says, well, I put everything you suggested into place and she's a completely different dog. And she's I've not seen any lameness since I've put all those measures in place. And I was absolutely delighted that actually those just little changes, which are so easy to implement, can make such a big difference. And the owners have been coming back for hydrotherapy, not necessarily for management of their toe particularly any longer, but for general fitness. But I'm sure it's going to be helping to a certain degree as well. So we see.
No, that's so true. That's why on our CAM advisory board we have a psychologist, because actually a huge amount of what we advise is lifestyle change, exercise management, and people kind of expecting us to make them purchase really expensive stuff. And you're like, no, let's just change how far you walk, how often you walk, what terrain you're walking on, and you're going to see some benefits. And people come back to me and they go, I don't understand. Yes, no, it's great, isn't it? So no, that's perfect. I just wanted people to be kind of like, not as you say, doom and gloom, but to think, okay, yes, I can now see the remodeling. Yes, I think they are causing a little bit of discomfort because when I flex and extend, he's trying to withdraw his paw. He's not too happy when we touch him. I don't want them to suddenly go, oh! There are things we can do about it, and quite often they're very, very effective and cost effective. Sorry.
And I think the most important thing here, Hannah, actually we discussed at the meeting, is that a lot of dogs hate their paws being touched. So don't go into a blind panic if your dog doesn't like having its paw being touched, because it might not be pain in that sense. It might just hate having its toes being touched. And it makes our assessments so difficult at times. And it's really trying to read between the lines what's pain and what's the dog just not about its toes being touched. So yeah, so if you've got a young dog, just play with its toes. It'll make assessment further down if it's needed a lot easier.
Yeah, no, absolutely. I say that to a lot of people now. I say, please make sure you touch your dog everywhere, so that when we do at any point in its life have to fiddle with something, they're not going to completely freak out. For people that are thinking, oh my God, well, how do I tell if my dog's in pain? Whether right or wrong, I quite often use distraction. So I'll have some nice food, some nice biscuits. Somebody else will be offering the tantalization, and I will go back and do it. And if they still turn around and go, actually, do you mind, mate? That's actually sore. If it overrides, I kind of sometimes use things like that, repetitive stuff. So, 3 or 4 times if I still, and I'm not pulling them, but I'm just, is it a consistent response is another thing as well, isn't it?
Yeah, absolutely. So there's, I think you just need to be mindful of that when you're examining your pet as well. I'm going to fly through these unless you want me to stop at this stage, but it's just some exercises to work on strengthening the foot, because as Hannah said, there's different forms of exercise that we implement, and there's aerobic exercise, which is you walking your dog to optimize optimize function and minimize pain. There's also targeted exercise, because what we want to try and do is offset the joint forces through strong muscular scaffold, I suppose, biological scaffold. And then we've got our flexibility exercises. But here's some strengthening exercises that I incorporate. So we want to teach our dogs how to grip, to try and strengthen up the toes and the feet particularly. So this is an exercise that actually would be considered, I suppose, post-surgery if you've got flexor tendon repair. But I think it's quite an effective one when I did it on this dog in preparation for my talk. Oops. We'll play again. But it's using an electric toothbrush, and you can see that he's withdrawing and flexing his digits there. So it's really nice, very simple, unloaded exercise to get those flexors working within the toes. So really, and then there's different exercises in standing. So these are weight bearing exercises. So you can do your balance and weight shifts. Top left, we've got our push and holds. We've got our leg lifts, you can see happening, and then our sort of parastanding, where you've got diagonal pairs lifted. Here's an isometric resistance. So I'm applying what we call a cranial caudal pressure. So I'm applying pressure over the front of the shoulder and sternal region, and he's pushing back, and he's having to grip with his toes to stop me from pushing him back. So the amount of pressure is really important there. This is my little dog called Watson, who's modelling. He's very happy with himself. And then you can start to incorporate some balance pads to improve grip. This is the Toto mats. Again, if you're using anything like this, I just be very vigilant of where you position your pet's toes onto, especially if you want to encourage flexion. I always find that, as you can see in this image on the left here, if you've got them on the downhill, I suppose, you're going to overextend those flexors. So just make sure that you position your pet safely on those. And you can see Watson doing it here. So he's really working. And I stood on this myself to feel what my feet were doing as well. And it's really interesting. And then if I play the second video, these are the pelvic limbs that are working there. So working the flexors and the hind limbs. And then you incorporate wobble cushions. If I've got the wobble cushion under the pelvic limbs, I always place the forelimbs on an equal but level surface instead of them being on the downhill, so to speak. Again, some demonstration videos of Watson working on the more knobbly surface as well. So he's working those flexors a little bit more. He's got something to grip hold of. And then the hind limbs as well, you can see. And with the treat in my hand, I'm getting him to do a bit of weight shifting as well to make it harder for him. So moving that head from left to right. And then finally, concentric and eccentric loading. So getting them walking on soft sand, for example, stepping over poles, walking backwards as well. So there's lots of other activities that will encourage flexor activity. But I'm glad to say that's the end of my talk. So I'm really sorry. I did warn people I like to talk a lot, and I can always...
No, it's amazing. It's amazing. And I think what's really great about tonight is that we brought out the neglected digital OA, which I've been wanting to do for years. But what you've been suggesting is, people can get on and do things like this. And back to what I said at the beginning, a big part of what we do with chronic pain management for musculoskeletal conditions is feeling like you're always saying, no, no, you can't do that. No, you can't do that. No, stop doing that. But this is an opportunity to say, yes, please do this. Yes, please do that. Spend time with your dog. Don't go and, trek 30 minutes. Do a 10-minute walk around the block and then spend 10 minutes doing some exercises and, massage, joint mobs, etc. So you still have that bond, which is what everybody's in fear of losing. So I love it. I think it's fab. We've got one question from a big fan of yours. You know this lady. I love her to bits. Melanie Bruder. Oh, here she is. Have you used silicone elastomer to promote toe alignment at all?
So there's, I haven't used that in particular. I wouldn't be averse to using it. So I've used like a memory foam cushion, self-adhesive cushion before. I haven't brought up the slides and I think we've gone on too long, but I haven't used that particularly, but I think it's an option certainly.
Yeah, Mel's amazing. Mel was right there at the beginning. She's amazing. If there are more questions, guys, please, get in touch and we'll try and tackle them at another time. I think I would love to just take one more minute and say, give us a big take home. So somebody who's kind of listened to this, they've just, had their dog diagnosed with OA, be it digital, be it carpus, be it, stifle elbow. If you could give somebody, say, 3 bits of advice for all that knowledge that you've had over the years, what would it be? 3. You got 3.
Don't underestimate lifestyle changes, and do listen to the therapist who you've met with or your vet, who hope, as we increase the awareness through Hannah's amazing work, hopefully they're starting to be able to advise you from a consult level in practice. So don't underestimate lifestyle changes because it does make a big difference. Don't be afraid of exercise. I think people hear osteoarthritis and their immediate thoughts are, oh gosh, the more exercise I do, the more progressive it's going to be, osteoarthritis. So don't fear osteoarthritis and don't stop doing it. Just talk to your therapist or vet about how you can modify it and make changes to make it appropriate for your pet. Oh, what's my 3rd thing? Gosh, Hannah, I don't know.
Probably wait.
That's probably wait. You know what? It's the NICE guidelines. I've just referenced the NICE guidelines. So it's one of the biggest things, and you can make such a big difference. Get that weight off your pets. But I do have so many pet owners, even still at the moment, that have difficulty. They say they're trying, but I think we need to get the food manufacturers talking to them more a little bit about what they're developing, particularly the ones that are with the European, I can't remember what it's called, is the EFA, the European Food Association, or I have not said it correctly, but the big 3 sort of, is it Purina, Royal Canin and
Hills.
Yeah. So do talk to them. They've got some excellent products in the market, will help with weight management as well.
Definitely. And weight management, I think I'm learning to manage people's expectations more and more now. People often come in and their dog hasn't lost weight. That first 2-week period, devastated. I'm going to lose them forever if I don't swing them around. I'm like, don't worry about it. How many women out there go for their first weight loss session and they put on pounds? And they're like, this is not happening. It happens to all of us. So whoever's doing these weight consults, there's a huge amount of hand-holding, psychology, empowering, motivating, detective work. I love my weight clinics now. I'm becoming like Benjamin Button of the vet world. I'm going back in time and enjoying all the things that I started off doing. But weight, 100% importance. You've got Macho Love here. There's just this one question and then we're going to go. My Labrador fractured 2 of his sesamoid bones on one of his front legs. He had laser therapy and is sound most of the time unless he overdoes things. Is there anything I can do to help him? You might have answered your question, my love, if he overdoes things. That lifestyle situation, I think, really is just encompassed with that phrase. Is there anything else you can think of?
I think, well, it's outside my remit, but Jennifer Brown was talking about steroid injections. So I guess if it was becoming more consistent and you weren't able to manage it with some lifestyle changes, then it could be considered. But you need to seek somebody that is experienced at doing that because it's such a delicate area or small area. So yeah, I don't know whether you would suggest anything different, but that's probably.
I think you all the things that you've talked about. So mobilizing, heat, all of those kind of conservative approaches. I think a lot of people hopefully will feel empowered to handle their dog's feet more. And this lady might be just hoping that she only just has to best manage the flares, and it might just be some medication when he's flaring. But now she might feel empowered to actually, throughout the time period, not just during a flare, keep them mobile, keep them warm, keep them checked out, use the toys, use the mats, and you might find your flares will actually reduce massively in frequency. With regards to good weight loss foods, there are many out there. Unfortunately, being live, we're not able to recommend any specifically, but get in touch and I'll tell you what I use. Cool. So thanks, Di. You're amazing. I think this is the most hardcore one you've ever done for us. So thank you. Really kind.
I'm sorry it was long and lengthy, but hopefully people can dip in and out of it as they want.
That's perfect. Thank you, guys, and we will be back, I believe, on Wednesday with amazing Tamsin Durston, who's going to be talking to us about the emotional impact of managing a dog with chronic disease, because it does wear us all down. So she's there going to be empowering all of us that we can all do it. So I will see you on Wednesday. Take care.